Okay, so let's continue on. So we talked about sudden cardiac death, okay. And so the next slide goes over chronic ischemic cardiomyopathy. Not much to say about that, even though it sounds like a big term. But all this means, just to kind of sum this up, is that as we age, unfortunately, our heart will actually start to slow down and function, okay, just like everything else. We do have a decrease in metabolism as we age. We know we lose collagen, all those things that happens from the aging process. Is it a possibility that the myocardium and circulatory system can slow down as we age? Yes. And so this could lead us into a slow progression of what is called a chronic ischemic cardiomyopathy, meaning that as circulation slows down, this could definitely lead to a possible ischemia. This happens very slowly, and it will progress to that again during the aging process. And so they say it is common in older adults, yes, and so just part of aging. Okay. Now, the next thing that we're going to go into, endocardial and valvular diseases. So now we're going to look at the inside of the heart and see what are some things that can possibly occur. We're going to talk about infections, and we're also going to talk about valvular disorders. Okay. So we're going to talk about inflammation and scarring that can occur inside the heart, also calcifications. As far as congenital malformations, I'm going to leave that alone, and we're going to add those topics to our topic list for week 8, okay, for a presentation. We just don't have time to squeeze all of that in, but anyone interested in doing congenital heart defects, you guys can pick that as a topic. So, before we get into what happens when a person has a valvular disorder leading into what is quote-unquote called a heart murmur, let's run over the normal heart sound. So, normal heart sound we know is lub-dub, correct? Also known as S1 and S2 heart sounds. So just to give you the full description, S1 heart sound is what is titled as the closure of the AV valve. So the S1 heart sound is the closure of the AV valve. So once the AV valve closes, that gives us our first audible, which is the lub. S1 heart sound is the closure of the AV valves. The S2 heart sound is the closure of the semilunar valves. The closure of the semilunar valves. And when we have that closure, that gives us the audible of the dub. So that gives us the dub. Repeat, yes. S1 is the closure of the AV valve. S2 is the closure of the semilunar valve. So S1 is the lub, S2 is the dub. Lub dub, lub dub, lub dub. Now, at any time you auscultate, listen to a person's heart, hear lub dub, and you hear anything outside of the dub, lub dub, lub dub dub, lub dub 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 dub, lub dub hub. Okay. Anything outside of the normal lub dub is considered to be a heart murmur. So a heart murmur is defined as an abnormal sound. It is not a diagnosis, it's just a finding. A heart murmur is an abnormal sound that's heard outside of the normal lub dub. So, now, what can happen when a person has a heart murmur? There's 1 to 2 ways they believe that heart murmurs can develop. They believe that these valves can either be in a state of stenosis or in a state of regurgitation. Okay, so we're going to go over the difference. So a stenosis is when there's a failure of the valve to open completely, causing the blood that's in the previous chamber or previous section is coming from to build up with pressure of that blood. So say for example, if we use the AV valve. AV valves we know kind of sit like this. When it's time for the valve to open up freely, unfortunately it cannot. So when it's time for it to open, it will just kind of open just a little bit, not all the way. And so this now leaves the blood that's supposed to be moving forward not fully able to move forward and now being stuck, okay, in that area. When we have a regurgitation, this is a situation where it's the opposite. So the valve has a problem closing when it's supposed to. So now let's say again we have the AV valve, blood is in the atria, and when the valve opens up, it moves to the ventricles, which is great. However, when it's time for this valve to close, it cannot, and it will just kind of try to close, but unfortunately not close all the way, leaving that space open. So when the blood that's in the, God bless you, in the chamber below, try to move forward, because of the pressure and contraction, it will now unfortunately slip back up to where it came from. Okay, so that's what happens when we have a regurgitation. So it regurgitates back. So we're going to go over, I think it's about six different types of valvular disorders. Okay, and I'm actually using colors. I'm going to color code the disorders on this part diagram for you so you can see exactly where the backup of blood's occurring, what's the issue, okay, in the heart when that person has that disorder. So the first one we have here is mitral stenosis. So I'm going to draw this on the diagram as closed, even though I don't want you to think when something is stenotic, I don't want you to think that it's like closed shut and it can't open up whatsoever. It's just not able to open up. Okay, so but I'm just going to show it closed. So mitral stenosis. Mitral stenosis, this is where the left AV valve or mitral valve, also known as, we know from anatomy, bicuspid valve. Okay, this valve has an issue, okay, where it cannot open completely. Which means blood that's in the left atria will try to move forward, but it cannot. So what's going to happen here, blood is actually going to pool up in this left atrium. Okay. Keep in mind, circulation is still occurring, so we still have blood dumping into the left side. So if that blood that keeps moving in can't go forward, it's going to build up in that chamber. So it's going to build up in the left atria, giving it sort of a hypertrophy and enlargement. But where else is this blood possibly going to back up into? Very good. Pulmonary veins and the lungs. Okay, so what's going to happen? This will back up into pulmonary veins and actually back up, and I don't have it drawn out here, but it will back up into pulmonary circulation. So when it backs up into pulmonary circulation, this can lead these patients into pulmonary hypertension because of the force of blood, all that pressurized blood backing up into that region. And it can back all the way up through the pulmonary artery into the right ventricle. It leads to right ventricular hypertrophy. And leads to possibly right-sided heart failure. Why right-sided heart failure? Because the right side of the heart cannot function forward as it should go into the lungs because of the backup of blood that's going into it. Okay. So keep in mind you have blood trying to move forward, but it's going backward. Okay, so this is going to actually back up into the right side and not so much cause an issue with the left-sided heart failure. Now, can it eventually cause issues with the left side of the heart in its function? Yes, but they do classify this as more so right-sided heart failure. Now, the sound, I'm not going to have you memorize the sound, however, I will describe it for you. So low-pitched rumbling diastolic murmur. So when we say it's low pitch, when you auscultate and hear this, the murmur itself overall is going to sound very low. So it's not like loud in your ear because some murmurs are louder than others. So this one is pretty low. The rumbling you will hear, it's like a lub-dub rumble. And you'll hear the rumbling through the dub. Now, you guys remember when you were auscultating and listening for the heart and practicing, and you kind of took the stethoscope and rubbed it against your clothing and you heard a rumbling sensation inside the stethoscope. That's the same rumbling that you'll hear. It sounds just like a rumbling because it is a rumbling effect because you have blood trying to move forward, but this is going backward, and so it's rumbling. Okay, and so that's what you'll hear. Okay, I have my picture, so we don't need to do that. Okay, so the next one we have is mitral regurgitation. So this particular one, I'm going to draw the mitral valve like that. So let's say it's opening, but it can't close all the way. So yes, we're going to have blood in the left atria moving to the left ventricle, okay, which is very nice. However, because this valve cannot close completely, when it's time for the ventricles to contract and push that blood to the aorta, because this valve is still open, the force of that contraction is going to cause the blood to splash back up into the atria. Okay, and so therefore it'll just continue to pull back and forth like that. And so you will have a pooling of blood in the left atria and in the left ventricle, both making it dilate and leading to left-sided heart failure. And this can both lead to left-sided heart failure. So the sound here is a high pitch, so it is a louder murmur that you'll hear pan-systolic blowing. And it does sound just like a blowing effect. I always use the example of like a toy whistle. If you ever use a toy whistle. So not just like a regular whistle, but if you would like to blow into something hollow, that's exactly what it sounds like. Okay. Final picture. Okay. Mitral valve prolapse. This one is a little different. So I'm going to draw this in purple, like this. So I know it looks weird, but I'm actually drawing the valve like this. Okay, so there's a reason for that. So let me explain. Mitral valve prolapse is, well, I should say all of these are considered to be like mechanical defects of the valve. But this one is definitely a mechanical defect. So what happens here, the valve actually will, remember, an AV valve sits like this. Normally in anatomy, we know chordate tendinate, attached to the papillary muscle, holding it in this position. The problem here with mitral valve prolapse, the mitral valve actually falls in this position. And so what happens, chordate tendinate relax and so forth, and so leaving it like this. Sometimes people can be born this way, or over time, the valve can just kind of, fall in that position. Now, they do say these patients are typically asymptomatic. However, I will say this. Most of the valvular disorders can start off asymptomatic. Usually sometimes people don't know they have heart murmurs until they go in and have it checked, just a regular physical, or if they have an echo done. Ultrasounds of the heart is definitely one of the best things to use as a diagnostic tool to see these valvular issues. Because if you have an ultrasound of the heart, you can see the valve in motion, you can see if it's closing properly or not opening properly, even regurgitations you can see. So that, I would say, is the best diagnostic tool for any valvular issue. Now, again, when we talk about symptoms, most of the times they are asymptomatic. However, if it starts to compromise a patient's circulation to where they're starting to have like issues with blood flow, maybe becoming cyanotic or leading to like having shortness of breath, paleness, okay, things that are really compromising their circulation, then they may have to look into, okay, possible surgery. However, we all know that people that have heart murmurs, they all don't run and get surgery done. Okay, so most of the times they just kind of watch and wait and see, okay, what's going to happen. But when they do become complicated, yes, they do have to go in for surgery and have the valves replaced. And most of the times, the cases I've heard are mainly like elderly patients that usually have their valves replaced. Although sometimes young adults can have that surgery done too if it, again, is really, really bad. So let me go back to mitral valve prolapse. Now, mitral valve prolapse, one of the main concerns they have about this is infection of the heart. I forgot to pull up this picture for you. Hold on, I'm sorry, I forgot to pull up the picture. So, have you guys ever heard of when patients, say for example, when they have dental work done, if they do have mitral valve prolapse or even other heart murmurs, that they have to take antibiotics beforehand? Have you guys heard of that? Yes? Yes, okay. Some people are saying yes. And the reason why is that we don't want these patients to lead into an infective endocarditis. So let me just explain how this works. What happens is this. Patients will have, let's say for example, if they're having a root canal done, okay? You're having a root canal done, obviously there's some sort of bacteria decay, okay, that was there in the first place while you're having the procedure. So when they're going in and having a root canal done, obviously that's going to start breaking up and opening up things. Now, is it a possibility that bacteria can go into the bloodstream? Yes, with that procedure. So what happens is this, when bacteria goes through the bloodstream and it goes through circulation, and then when now it's time for it to hit the heart, the issue is that normally the AV valves are situated like this, okay, so where if anything flows through, it'll just go and continue. Problem is with the mitral valve prolapse, it's like this. So now you have the avenue for bacteria to just sit there on the valve leaflets, and then it will start to form these colonies of bacteria. And it'll just sit there and now start this infection in the heart. And so this is a picture of what it looks like. So all that yellow stuff there is actually bacteria. So this is what they try to prevent, because they know that since they have this alteration, this can lead to this type of infection just settling right there in the valve. So, another thing that can happen, again, and it all depends on the severity. If it gets severe, yes, it could lead to death, and it could lead to cerebral embolism, and it could lead to mitral regurgitation. Why? Because if the valve is sitting like this, do you think it could close properly, open and close properly? No. So sometimes it will not close properly, which could lead to regurgitation. Now, the sound is what they call a mid-systolic click. And so if you do ever listen to this or hear it, you'll hear it as lubbed up click, lubbed up click. So it's an extra sound heard behind the lubbed up, but it sounds like a tapping sound or a clicking sound. And the reason for that is because when the valve is situated like this, when it opens and it's time for it to close, it really has to use a lot of force to close, so it kind of snaps. It's an extra snapping that happens behind the duct. Aortic stenosis. This is an age-related, they say, calcium deposits in the aortic cuffs. So what is an age-related disease that you think could cause excess calcium in the bloodstream? Very good, osteoporosis. So osteoporosis, we know when that bone breaks down, all that excess calcium can flow through the bloodstream. And what can happen is, unfortunately, when it goes through circulation and goes through the heart, for some reason, this calcium can deposit and pool up right here in the aortic cuffs of the semilunar valve. And so if you remember from anatomy, the aortic semilunar valves are kind of shaped like a half moon, like little cups. So it's a prime location for those ions to get trapped there. Now, when that calcium sits there, I want you to understand that this really makes the valve heavy. So it makes the valve heavy, and that's why it's a stenosis, because it makes it heavy to the point that it cannot open all the way. So when it cannot open all the way, what's going to happen, obviously, there's going to be blood building up in the left ventricle. And they say that this can result in ischemia. And the reason why, if blood's backing up here, that means we're not getting enough blood getting through to the rest of the body. So that's going to lead to our tissues being ischemic and possibly leading to a left-sided heart failure, okay, because things aren't moving in that direction as supposed to. Now the sound here is what they call crescendo, decrescendo murmur, meaning that high and low, and it does sound very strange if you ever hear it. It sounds really loud, and then it's low, and then it's loud, and then it's low. They do consider this a prominent S4, so if you were to look at, and they even have it in your laboratory value sheet in the back, they go over all the different types of heart sounds. So S1 and S2 we know are normal, but S3 and S4 heart sounds are considered to be abnormal sounds that are heard, especially related to cardiovascular conditions. And then I think if I can remember, babies normally have an S3 up to a certain age or something like that. But in any event, S3 and S4 are abnormal in adults. Okay, and so that is considered to be a murmur, and they consider this one S4. Okay, and then the very last one is aortic regurgitation. And so this one, as you can imagine, the valve is open, it won't close. We're getting blood going through, very good. Unfortunately, believe it or not, the aorta has to contract too to push and convey that blood even further. So when it contracts, because this valve is still open, it'll actually splash back up into the left ventricle. So this can lead to left ventricular hypertrophy and possibly lead to left-sided heart failure. The sound here is a high-pitched sound when you hear it, and it's blowing just like the mitral regurgitation, so you hear that blowing sound. And there's that. Now, what do you notice about all of these heart murmurs? They're all on the left, okay, which I want you to know that most of the valvular disorders do happen on the left side of the heart, because the left side of the heart actually does most work, or the hardest work, I should say. And so they are more common on the left side of the heart. Not to say that the right side of the heart, you can't have valvular issues, you can. However, the left side is way more common. And again, don't forget that the best way to diagnose this outside of auscultation, auscultation you'll hear obviously the murmur, but once auscultation is done, at some point to really confirm what's going on, an echo should be done, so an ultrasound of the heart should be done to see exactly what valve is the issue. Is it a stenosis? Is it regurgitation? So it gives you more definitive diagnosis. And that's that. Okay, we don't have to worry about this stuff. Okay, now let's go into infections. So there is something called rheumatic heart disease. Okay, and some of you guys may have heard of rheumatic fever. Okay, so this is correlation with that. So we do have infection where it is a bacterial infection that can attack the heart. Okay, and so this particular infection is from group A, beta hemolytic streptococci. Not sure if you guys went over that in micro, but this type of bacterial infection can invade not only the heart, but it can also invade, they say, the joints and the skin. Okay, so it does invade other areas. Now, the signs and symptoms with these patients develop this infection. In the beginning, they will have a fever and a sore throat. And so they'll have a fever, sore throat, but then they will also start to eventually have damage, okay, to those organs as it progresses. Now, this disease is definitely found mainly in children, they say. However, I did hear a case, one of the students were telling me her grandmother actually died from a complication of this. As a child, I guess she developed the rheumatic fever. I guess it wasn't treated in a timely fashion, and so by that time she started to have a lot of damage in the heart. And she kind of lived with that for the rest of her life. She was told to have heart surgery. She opted not to have it, and unfortunately she died. And so her heart compromise came from the infection, okay, that occurred years ago. So just keep that in mind. Now, other signs and symptoms in the heart, these patients will have erosions in the heart. So the bacteria can definitely infect the heart to the point that it'll just start to erode and wear it down. It can also cause valvular swelling, so you'll have swollen valves of the heart. So swollen valves. And then they can also have clumping of platelets in the heart. And so how do you think you would treat this? Because we have a causative agent, antibiotics. They do use antibiotics to treat this, and then obviously any other drugs or things they need to do to manage the side effect. Is that oh, that's cool. I've never seen that. Oh, okay. Okay. So, infective endocarditis. This is where, I already showed you a picture, okay, of the heart, and so the valves actually have that bacteria that builds up. So keep in mind, I gave you the example of the root canal, okay, which is usually one of the things that they're concerned about, especially with dental work and in other surgical procedures. However, I want you to know that this can happen anyway. So even if a person just gets an infection from one of the common routes of injury, whether they, let's say, cut themselves or, you know, have a really bad infection through the skin or breakage, and that infection spreads to the heart. So it can happen anyway. The most common bacteria will be strep and staph, so I would make sure you know that, which is the most common forms that do occur. And they also have the same signs and symptoms pretty much like rheumatic heart disease. So these patients will have a fever, and they'll also have flu-like symptoms. So they treat this also the same way, God bless you, with antibiotics. All right, so the very last thing that we'll do myocarditis. So let me just write something in that word. Now we just went over two types of endocarditis. And so with endocarditis, when you think of endocarditis, I want you to know that this is usually caused by a bacteria. So it's going to be some sort of bacterial infection. When we talk about myocarditis, so believe it or not, there can be an infection to the myocardium that can also give an infection. And so this is where it's usually caused by a virus. Okay, this is a viral infection when we hear myocarditis. So we're just going to stop here. Okay, so just to kind of leave off with this. Myocarditis is an inflammation, again, of the myocardium, usually due to viral agents. And what I want you to understand, and you don't have the rest of this picture, but I just want to show you really quickly. If you have a viral infection to the myocardium, the only thing, that what it's going to do is change, obviously, the myocardium of the muscle. So the muscle can get dilated, it can get hypertrophied, it can get restrictive. So it's going to change the muscle itself, which obviously is going to change how the heart contracts, okay? Which throws off cardiac output and everything else. So just to leave you with that. But that's it. That's it. We're done.